So we've got to talk about in the hospital, order sets that exist, whether the order sets that most people have in the hospital, most physicians have access to, most nurses, pharmacologists set up, whether these right now, given the results that we've been talking about, are current, and whether they're the best that we can do. Where do we start? Orly, you want to start with that?
Sure. So if we take a step back and think about the reason that order sets were created is because we're busy clinicians and we want to be able to click on something and have everything magically appear that we want the patient to be on in a particular scenario. So those are mainly based on guidelines. And when guidelines are updated to include new medications, the order sets need to be updated as well to include those new medications. Now, whether order sets lately, as of the past year, have been updated to include some of the new medications that we talked about, most of the time not yet. Some places have adopted and incorporated into order sets, but not everywhere.
It's challenging, though. I think heart failure management is well suited to admission order sets that give you a start. But because I think in Orly you said it nicely that this is not a recipe-driven strategy, it's a bit more of what some have called the Chinese menu. There's a little bit from each column A. We know that you need ACE inhibitors, we know, or ARBs, we know you need beta blockers, we know some people need spironolactone or eplerenone, we know that some people need sacubitril valsartan, and then there are alternatives we haven't even begun to talk about. And so it becomes very difficult to script the right regimen for every patient. But I think you can stimulate clinicians to think through the decision-making by giving them options when the patient comes into the hospital, and if they're not on classic medications, asking them why not.
You know, what comes to my mind is the research that we discussed, which was pretty dramatic in terms of showing that there's an advantage to the ARNIs. Are the ARNIs now, as far as you know, on some of these order sets? Are they on discharge order sets, admission order sets? And if not, why not? And what can we do to change that? You want to give us a start on that?
So I think it's, as Akshay was saying, it's not an automatic that everyone should be switched or should be taking a particular medicine or another. It's individualized. So therefore, it's difficult to put it on the order set to automate that
Well,
piece.
wait, let me just stop you, because I heard that argument when order sets were first initiated. Every patient is different. Nobody is a classic patient. You can't tell me what to do on a piece of paper, and nobody's asking you to do that. But I could say, I'll give you an example. If you're sending somebody home with a diagnosis somewhere in your electronic medical record of congestive heart failure, and I know we don't use congestive heart failure anymore, but let's say heart failure, you can have a box pop up and ask, did you consider ARNIs? Did you consider this? That's not so bad. And it flies in the face of your argument that everybody's different.
So there's a minor complication. It's only minor.
Oh, I'm dreading this right away, because when they say it's little, it's not.
The minor complication is that in this very, very large trial was studied in outpatients with heart failure, with symptomatic heart failure, not patients who were acutely decompensated and in the hospital.
Okay.
So it was, in terms of the label and how it's indicated, does not include starting in acutely decompensated patients as of right now.
Right, and I think this is a really important point, because we did
I
not.
told you it wasn't small. It's big.
Well, technicality.
We didn't study in Paradigm the acutely decompensated heart failure patient. We also didn't study patients who were in the hospital and then stabilized. We studied, for the most part, outpatients. Now, I don't believe there's any such thing as a stable heart failure patient. These patients are all very high risk. But some would argue that before we start using this in the setting of acute decompensation, we need more data. Now, the current guidelines and the FDA label does not prohibit use of the drug and starting the drug in the hospital. And frankly, as a clinician, I would say that in a patient who's been hospitalized for acute decompensated heart failure and is then stabilized and is getting towards being ready to go home, as far as I'm concerned, that's a perfect time to think about switching a patient.
I was listening to you, earlier.
Yes.
When you said that being put on an ARNI decreased the risk of readmission
Yes.
by somewhere around 20%, give or take. That implied they were admitted.
Akshay said that, not me.
Akshay said
but-
that.
but-
I did hear it. But the point is, it decreased the risk. Well, then we'll go to Akshay. The risk of readmission. Doesn't that imply that they were using it on hospitalized patients and that it was part of their discharge medications?
So the challenge in the trial is that patients were randomly assigned to one drug or another
Okay.
during a period of stability in the ambulatory setting. And then they became hospitalized. And so when we're looking at readmissions there, we were looking at readmissions that happened during the natural evolution of their disease. So it's a little bit of a different situation.
Okay.
And I think
And
it does make, Scott's point is valid. I think it ultimately also makes the point that, that really what's, the challenge in implementing this strategy is that our historical approach to heart failure therapy is that when patients get sicker, we add medications. And that's not the case with this particular compound. It seems to be the case that it's the patient who is the walking, talking ambulatory patient, mildly or moderately symptomatic with low ejection fraction, who really deserves the switch. So
Okay.
we're not waiting for instability to make the change.